Good afternoon and welcome to today's wellness program. My name is Claire Varesio and I am the community librarian over at Cupertino Library. I'm so pleased to see all of you here this afternoon. Our wellness programs focus on promoting everyday health and wellness, and I hope you will learn from and benefit from today's program. When our program concludes, please remember to visit us at our back tables to get a book list of additional resources, to sign up for the Cupertino Library Foundation email list, and also to take our program survey. And before I introduce our speaker this afternoon, I'd like to invite Gopal Kumarapan from the Cupertino Library Foundation to say a few words. Cupertino Library Foundation is our funding partner for today's program. Thank you.
Thank you and welcome everyone. I think it's Sunday afternoon after a good lunch, but hopefully Dr. Ron will keep you really busy and he is planning to do some exercise for you, or he will make you to do some exercise, right, Dr. Ron?
Absolutely.
So that you won't feel sleepy. By the way, my name is Gopal Kumarapan. I serve as in the board of Cupertino Library Foundation, and this is one of those wellness series, one of the programs we bring into the community, mainly just to bring an awareness so that you can go and practice and bring the best health to our life. Like education and wellness, both goes together, because if you don't get educated properly or bring awareness on what we do, I think we take it for granted. And with a busy life, we forget very basic things. And I personally listened to Dr. Ronesh Sinha like 7 years back when I was at Oracle, where he comes and used to come and teach us and tell us what all these different programs. So I am personally a beneficiary of his lectures and listening to it and put together. And so I don't take any medications, and cholesterol levels have gone to a better level and definitely helped. So that's one of the reasons I said, okay, I need to go and somehow pull Dr. on again, bring in here so that he can share his experience. Not just to you all, and since it is being recorded, it will be available on the site for the rest of the community to see to it. Please share that information, not just our own community member, anybody you think that your friends and family, that this is such a great information which they need to be aware of it. So with that, I really welcome Dr. on to make sure that in the next 1.5 hours to make it really useful, and definitely you won't feel sleepy. I can guarantee that. Thanks, Dr.
Thank you very much. Thanks for that kind introduction. All right. It's such a pleasure to be here. I've seen a lot of people that I've seen at other events, and if you're familiar with my talks already, I'll warn you that this is going to be a roller coaster ride. There's going to be a lot of information. Hopefully, I will keep you awake during the talk, but the good news is they are recording it. So I keep my lectures pretty information-packed, so I will do everything I can to explain all the details behind all the concepts I've learned from my own research, from my clinical experience. But if there's anything you're not catching, follow the blog, look at the recording, you'll find all the information through that. So just my background, so I'm an internal medicine doctor and I work for Palo Alto Medical Foundation, but really my day job is I drive up and down Silicon Valley designing health education and wellness programs for high-tech companies. And the reason I got involved with that is because when I started my practice over a decade ago, I started seeing people in the clinic that looked very different than what I'd learned about in medical school. So I was typically taught with case studies that a typical heart disease patient is somebody, typically a Caucasian who's above age 65 or 70, who eats a lot of red meat and smokes a lot of cigarettes. So that's sort of the vision we were sort of taught in medical school. And then all of a sudden I got here, and my practice, which is right next door to Oracle, I started seeing a totally different face. I started seeing people that look like this. Okay, so much younger, several decades younger than what I learned. Many of them were not eating red meat. They were eating foods like this, Asian, sort of East Asian, Pan-Asian type foods. Many of them were vegetarian. They weren't really smoking cigarettes. Oftentimes the cigarettes were not their addiction. It was more a digital addiction. So very different version. So definitely I still saw the former in my practice, but I was seeing a lot of this sort of risk too. People of different ethnic backgrounds, early onset heart disease, and different risk factors than what I'd learned about in medical training. So I want to start off with a case study because I think these really hit home. This is not really a true person, but I'm just identifying some data just to give you a little bit of an idea of the types of case studies I see. So let's call this gentleman Sam. He's a 38-year-old software engineer. He eats a vegetarian diet. He has a body mass index, which is a composite of your weight and height, of 24. He's got a normal blood pressure and blood sugar. He's got a total cholesterol level of about 190. So you might be familiar with total cholesterol. We'll talk about it in detail, but often you'd think that a total cholesterol of less than 200 is fine. And then he visits the gym 2 to 3 times a week, but is otherwise sedentary and work stress is high. Can anybody relate to this sort of a composite? Does it sound familiar to people? I see a lot of head nods there, right? So what happened to Sam is at 3 a.m. on a Sunday morning, he was woken up by progressive chest discomfort. He thought he was having acidity, bloating, maybe I ate too late. So he took an antacid and he didn't have any relief. Thank God he's married because men are in denial, but the wife knew what was going on, so she called 911 right away, and he was rushed in the emergency room and he was diagnosed with a massive heart attack due to a blockage in a major artery of his heart. So this is what we see day in and day out, but what I've really been struck by over the last decade is the escalation in the rates of heart disease I'm seeing, the diversity of ages and ethnic groups that I'm seeing. So I think the key way to motivate you today is to teach you what exactly is happening inside your body when heart disease and chronic disease strikes, because I can't motivate my patients unless they understand what's happening in their body. So I'm going to spend a lot of time teaching you what's happening, and then the lifestyle information will make much more sense. So this basically is a busy slide, and it shows 2 major processes which we're going to learn about today. The first is inflammation. It's on your left side. And the one on the right is insulin resistance. And all the little thing that you see, I don't know if you can really see all the conditions around there, almost every chronic health condition is linked to some combination of insulin resistance and inflammation. We're talking about heart disease today, but all the risk factors we're going to talk about influence cancer, diabetes, Alzheimer's disease. I give a separate talk on brain health and Alzheimer's. Alzheimer's epidemic is out of control right now, and many of the processes that cause heart disease actually cause Alzheimer's disease as well too. So this talk will definitely help protect your heart and your brain. Now, the first process is inflammation. What is inflammation? Okay? So if I sprained my ankle right now, you'd see my ankle would swell up and turn purple and red, and that's actually a protective mechanism. If you injure yourself and your ankle gets swollen and red, that's going to prevent you from moving in different directions. It's going to keep your ankle stable. So that is visible external inflammation. But when you develop chronic health conditions like autoimmune disease, cancer, heart disease, etc., there is invisible internal inflammation taking place. And it basically looks like this. The same immune system that protects you against infection becomes overactive on a regular chronic basis because of your lifestyle. And all these little cells that you see, they start attacking your own blood vessels. And that's really what leads to the plaque formation. So in the old days, we used to think that heart disease was a disease of plumbing, right? You think of your arteries as being pipes, and basically it's accumulating with all the foods that you've been eating, a lot of fatty foods, and then it gets blocked off. But actually, heart disease, most heart disease is due to less than 50% blockage of that pipe. Most heart disease is due to very small plaques that barely occlude that actual blood vessel. So what happens is when your immune system overreacts, it causes that small plaque to rupture, and then it erupts like a volcano and actually blocks up the blood vessel. So it's really a completely different situation than what we'd anticipated during medical training. So this is a signature slide. I'm going to spend some time on this, but this will teach you what really happens in most cases of heart disease and how your diet and food is indicated in this. So basically at the center of the diagram, you see a car. I call this the carbohydrate car. Okay, I'm going to teach you what insulin resistance means, because this is really a fundamental process that leads to most of these conditions. So let's say we've got that carbohydrate car in the middle. We've got 3 parking lots in the body. You've got your muscle at the top left, the liver in the bottom, and the fat parking lot on the right. Every time we eat carbohydrates, excessive amounts, we want the glucose to actually go to our muscle parking lot because our muscle can burn the glucose for energy. That's the ideal destination. The way the carbs get inside the muscle is by using a parking pass called insulin. Okay, so diabetics that inject insulin for their blood sugar, it's pushing the glucose from the carbs inside the muscle so they can use it for energy. Now here's the problem in most situations. What we're seeing now in our modern civilization, this epidemic insulin resistance, is our body is producing the insulin parking pass, but the muscle saying, sorry, I'm not going to respond to this signal. I'm not going to let the glucose in. So when that happens, you have all this overflow traffic, and that overflow traffic goes in different directions. It might go to the fat parking lot, especially the belly fat. It might go to the liver, and the liver converts those carbohydrates into dangerous cholesterol particles called triglycerides. And how that overflow traffic is distributed varies in each person's body. So for example, I'll give you an example. A lot of times I see couples in my clinic, okay? So I'll see often maybe a slender male, and then the wife might be 20, 30 pounds overweight. It can go the other way too, so I don't want to make any generalizations here. But usually what I explain to them based on that composite is that in the case of the slender male, what's happening is he doesn't have much carb traffic. He's got some carb traffic going towards fat storage. A lot of it's going to the liver to make triglycerides. That's why I see a lot of slender people of all ethnic backgrounds, but especially Asians and Indians, who don't have much body fat, but they have very high triglycerides and fatty liver. So despite them not looking very unhealthy, they're very unhealthy based on their lipid profile. And a lot of the women, especially before menopause, a lot of the carbs go towards fat storage in them, not much to liver. So although their body weight's heavier, the cholesterol doesn't look as bad. So as much as they are very jealous of their husband's body type, I tell them right now at the rate we're going, you're going to way outlive your slender husband. Okay, so really you have to understand how that traffic's distributed. And our fundamental goal when we talk about lifestyle changes is we want to reroute traffic. We want to get the carbohydrate car moving back towards muscle and away from these other dangerous sites. That's essentially what we're going to talk about. Now, the process of atherosclerosis, that is the process where plaque formation begins, the plaque that can cause heart attacks and strokes. And one of the things I'm going to talk about at the end of this talk also is this is a process that starts in childhood. Okay, this is a fundamental thing you have to understand. Plaque formation starts in the first decade of life. It doesn't start all of a sudden in your 50s and 60s. I mean, things can accelerate that, but a lot of what we do in our childhood and teenage years can lay the foundation for plaque formation. And when I talk about children's health a little bit towards the end, hopefully I can motivate everyone to sort of make multi-generational changes to reduce the risk of heart disease. As we talk about heart disease risk, these are the 5 worldwide factors that are linked to over 80% of heart disease. It's abnormal cholesterol, it's high blood pressure, it's diabetes, it's obesity and smoking. And when we assess heart disease risk, these are the categories of risks that I look at. I look at your biometrics. I'll teach you what your numbers mean. When you go to get the doctor's office and you get the lab tests back, there's specific things that you have to look at that are very different than what you normally think. So I'll teach you how to do that. The second thing is genes. So nowadays we are in the era where we can check people's genetic information. But right now, just to keep things simple, we assess genes by just assessing your family history. And then the third thing is we assess your lifestyle risks, stress, physical activity, etc. So let's talk about cholesterol first. So when we talk about cholesterol, so this is an image from the book that I want you to understand. So you're looking at these 2 boats. So I'm going to start off and talk about LDL cholesterol. So if you've had a cholesterol panel done, you'll see a breakdown of different numbers. LDL is typically thought of as the bad cholesterol, but I want to spend a little time and teach you about this cholesterol particle and what it does, because then the numbers will make a lot of sense. When you get a standard LDL cholesterol panel done, there's just one number, but there's actually 2 different types of LDL. And I tell people these LDL particles, they're like boats that carry cholesterol through your bloodstream. And there's 2 types of boats in our body. There's a type B on the left and a type A. The type A boats are larger LDL particles. The type B are small ones. And you would think that the large ones would be more dangerous, but it's actually the small type B particles that are the ones that are more dangerous. They're the ones, if your body has more type B LDL particles, those boats tend to anchor into the blood vessel wall. So I'm showing you, if you think of the inner lining of the blood vessel wall, I show that layer right here. If you were to take like a tube and open it up, let's think of like a toilet paper roll, you open that up and that inner lining is where the damage happens. So type B particles tend to stick to the endothelial cell layer and cause more damage versus type A. And I'll teach you how to figure out what type you have even without doing advanced lab tests. The reason those small particles are so dangerous is they're kind of like a pack of, let's say, mischievous teenagers. When they hang out inside the blood vessel, the small particles, they tend to not flow through the pipe very much. They tend to stick to the blood vessel wall. So when you have more type B LDLs, they will stick to that wall much more avidly than the type A. They're also more susceptible to damage. These are like little hand grenades. When they attach to the blood vessel wall, they can oxidize, which is a process that causes the particles to become unstable, and they also attach to glucose molecules. So basically, remember, small is type B, B is for bad. Type A isn't great. If you have a lot of type A, that's dangerous too, but that tends to be less harmful than the type B. Now, what about the other number? We talked about this a little bit. This is the triglyceride number. And this is a number I focus on a lot. If there's one thing you should take away from this talk is know your triglyceride numbers. And if they're elevated, fix them as soon as you can, because triglycerides are the #1 cholesterol risk factor I see in the clinic today. Triglycerides are basically a storage form of fat. So when we gain body fat, our fat cells actually get filled up with triglyceride particles. When your blood has elevated levels of triglycerides, that's a sign that you have insulin resistance. You've got the carbohydrate traffic problem to some degree. It's also an early trigger for plaque formation, atherosclerosis, and then here's the most important part in our cholesterol section here, is it leads, when you have high triglycerides, it leads to the formation of more of the small type B LDL particles, the dangerous sticky particles, okay? So this is a bit of a complicated graph, but I just want to show you just to make the point that as your triglycerides go up, so that's the x-axis right here, as your triglyceride levels go up, that green graph is dropping, your LDL particle number goes down. This shows that inverse proportion basically. As triglycerides go up, LDL particle size goes down. So even without, so there's a specific way you can check your LDL particle size. There are advanced tests that you can do, but you don't always have to do them. If you looked at your triglyceride number, if it's above 150 and especially above 200, you're almost guaranteed to have more type B particles. Above 100 to 150, you might have intermediate risk, but really when you get up above 150 to 200, you start generating more of those particles. Now, healthy cholesterol, HDL, the job of healthy cholesterol is it removes some of that cholesterol away from the blood vessel lining. So the more we can elevate HDL cholesterol, we'll talk about how to do that, that can help basically reduce some of the heart disease risk. It also lowers inflammation. It keeps the blood thin so it doesn't clot in the blood. It keeps the blood vessels less stiff. And again, this is why I obsess over triglycerides. High triglycerides push down HDL. So if you look at your lab panels over time, you'll see that they tend to be inversely proportional. If you get enough lipids done, you'll see the higher your triglycerides are, the more it pushes HDL down lower. So the easiest way to fix it is to lower triglycerides. Over time, the HDL should float up. So to make it easier, let's put some of these principles into practice. Let's look at Sam's cholesterol results. What led to his heart disease? And often, if you don't, I wish I could say that all doctors are trained to interpret cholesterol panels like this, but unfortunately they're not. This is a typical type of profile where his doctor told him that your numbers looked okay, and he had a massive, almost life-ending heart attack. So it's going to be your job to interpret these numbers properly because your doctor may not know this. So basically, look at the test results. The total cholesterol is 190, okay? Target level, I put not important because some people with really good cholesterol levels are above 200 because they have such high levels of HDL cholesterol, right? So that's why total cholesterol is not very useful. The LDL, the bad cholesterol, 108 was his number, and most doctors would say less than 130 or less than 100 is okay, but I kind of put that, I'm not really as concerned about LDL. Let's come down to the other numbers. The HDL, 32. So normally it should be greater than 40 in males, greater than 50 in females, but his was 32. Triglycerides, 250. The cutoff typically on most labs is less than 150. Less than 100 is ideal. If we can aim for 100, the particle size shifts and the ratios get better. This is important. Different healthcare systems use different cutoffs. Most will use 150. I'm aware of a medical system in the Bay Area that uses a cutoff of 500. So if you have 300, 400, you might be told by your doctor that it's normal. It's crazy. I've had patients come from India telling me, as long as it's below 700, don't worry. They see so many patients, they're like, oh my God, okay, as long as but most heart disease is happening in the 150s, 180s, 200s, between 200 to 300. So in this case, it was 250. Now here are the really important ratios. Probably some of the most important information from this talk is TC to HDL ratio. That's your total cholesterol divided by your HDL. So you take his total cholesterol, you divide it by the HDL, ratio is 5.9, should be less than 4.0. Most lab reports do report that number. The number they don't tend to report is the triglyceride to HDL ratio. Be sure you calculate that on your lipid profile. Take your triglycerides, divide it by the healthy cholesterol, and see what you get. In his case, his number is 7.8, far above the 3.0 cutoff. So those ratios are lifesavers. If you look at absolute numbers, you might think he's not really high risk. But when you look at the ratios, you realize that he was a ticking time bomb. So this is really critical. So be sure you understand these numbers. So the problem with our current approach is 70% of heart attack patients today, based on a huge UCLA study, they have normal cholesterol levels. Their total cholesterol looks fine because they look like this guy. Total cholesterol is less than 200. LDL looks pretty good, but they're still coming in with heart disease. That's why it's so important for you to understand what these numbers mean. Like I said, the LDL can be misleading. You can have a low LDL and still be very high risk. There's not enough emphasis on triglycerides, and most people don't know how to raise the HDL effectively. The other problem with today's approach, too, is what happens when you see your doctor you have high cholesterol. Most likely, they're going to put you on a statin like Lipitor. Studies have shown the minute you put somebody on a cholesterol drug, on average, they gain 8 to 10 pounds within 3 months. Why is that? Because they're like, hallelujah, now I can eat whatever the hell I want, right? My cholesterol went down 70 points. I'm going to go party. I'm going to eat whatever the heck I want, right? That's a problem. So you see weight gain. So cholesterol drugs, what they do is cholesterol drugs are very important. I'm not undermining them. In the right patients, they're important, but you have to also know what they also don't do. They don't reduce visceral fat. They don't lower inflammation in the body. They lower inflammation maybe a little bit. They can lead to worse insulin resistance over time. There's a definite link between statin medications and increased diabetes risk. So definitely in high-risk people, it's important, but don't think because your numbers are better on a statin that you're bulletproofed. If anything, you have to be more careful about your sugar, carb, and physical activity, because over time you might develop another complication. So how do you deal with this problem with the high triglycerides and low HDL? We'll dig deep into this, but a few key things I want to sort of give you off the top is that we have to cut added sugar as much as we possibly can. We want to remove some of the excess carbohydrates, and I'll tell you how to do that. It is a carb-driven process, the triglycerides. As much as triglycerides are called blood fats, it's a carb-driven process. So that's why a typical low-fat diet traditionally and typical Indian vegetarian diets that are very carb-heavy, those are the patients that have some of the highest triglycerides I see in the clinic. They're wondering, how did I develop heart disease? I don't touch ghee, I don't touch butter, I don't eat fat, but I have heart disease. I've got triglycerides above 400 because it is a predominantly carb-driven process. That's the main thing I'm telling you. Then increasing physical activity, we'll talk about structurally how we can do this in typical types of diets. A real key to keep in mind. What about LDL levels? I put if they need improvement, because sometimes people are told you have an LDL of 130, we need to bring it down 140, but all their other numbers are fine. They don't necessarily need to be brought down. But if you do have elevated LDL, the ways we do it is we want to increase natural fiber in the diet. Fiber is an LDL lowerer. I put mostly through vegetables. I'm not anti-fruit. Fruit has enormously healthy, beneficial properties. But what I sometimes see is in an effort to lower LDL, people are making fruit smoothies, and they're adding a lot of fruits into their diet, and that can raise your triglycerides. So you're trading one problem in for another. Well, that's why I said if you're overweight, be careful of excess intakes of fiber foods that have a lot of carbohydrates, like oats, wheats, and grains. Emphasize healthier fats, which is key. We'll talk about that. Activity and exercise. And there are supplements called plant sterols, which are very safe to take. You can find them at Target. You can find them at Costco. If you have a stubbornly high LDL, you can take plant sterol supplements. It's a type of plant cholesterol that can bring down LDL. The next risk factor is blood pressure. So how high is too high? So just so you understand what these numbers mean, a perfectly normal blood pressure where there's no increased risk of heart attack and stroke is 115 over 75. Now, for every 20 points that top number goes up and 10 points the bottom number goes up, you're basically incrementally doubling risk of heart attack and stroke. So that's why if you go up to 135 over 85, that's 2 times the risk. And going all the way up the scale, it gradually has a doubling effect. So anything above 120 over 80, which is a common number, already elevates your risk. So you have to really be aware of that. So if you ever have any high blood pressure, be sure you monitor it. I know you might be checking in the doctor's office or at Walgreens, but get a home blood pressure cuff and check it at different times of the day to see where your average number is. Your cuff should be large enough. One of the common false elevations of blood pressure is if people get a cuff that's too tight. I noticed this with one of my relatives. They were wearing a cuff that was way too tight, and that was falsely elevating their blood pressure. The minute we got a normal cuff, the number was actually fine. So make sure the cuff, you'd err on the side of the cuff being a little bit on the larger side, and then share your home recordings with your doctor. Now, what are the contributing factors? Now, unlike cholesterol we can reverse almost most cases with lifestyle changes. Blood pressure we can too, but genetic factors do tend to play a role with blood pressure. So family history is a factor. Stress and sleep I put at the top because these are the two that people neglect. Everybody focuses on salt in the diet. I got to lose more weight. Those are all important. Salt is becoming less important. I did a very detailed blog post on the connection between salt and blood pressure, and you'd be surprised to find that the link is not as strong as we used to think. So salt really is, if it's coming from processed packaged foods, that has an impact. But if you're making stir-fried vegetables and healthy foods and you're adding salt to that, that's probably not going to have much of a blood pressure elevating effect. But here in Silicon Valley, when people are not able to manage their blood pressure, we're piling on more meds. it is the stress and sleep that is often the most important factor. When we can get the stress and sleep managed, we often see dramatic reductions in blood pressure. But those are the two factors people want to ignore the most, right? They'd rather exercise more and diet and do everything else, but doctor, please don't tell me to meditate, for God's sake, right? That's always the one they're afraid of. What's go to bed early? No way. Just maybe exercise more. But those are the two that have a huge impact. Excess weight, especially the belly fat, inactivity if you're spending a lot of prolonged time sitting, and then, like I said, sodium coming from processed foods, not necessarily the salt shaker, but if you're eating a lot of packaged processed foods and you're not getting enough potassium. So the balance of sodium to potassium controls how stiff those blood vessels are. You don't have to measure it through a blood test. If you just limit your processed foods, your sodium ratio is going to go down. And if you eat more plant-based foods, think potassium, peas for plants. Nuts, seeds, and vegetables will elevate that. And by switching that ratio just through dietary changes, the blood pressure over time can come down. And then be careful with alcohol. For some people, they're very alcohol sensitive. Even a glass of wine, for most people, a glass of wine is not an issue. We'll talk about alcohol later. There's some really compelling studies that just came out last month. But for some people, they are very alcohol sensitive. And I tell them, just hold off on the alcohol for 2 to 3 weeks, check your blood pressures at home and see what happens. If nothing happens, there's no net effect, you can probably add it back. But just keep in mind, some people can be very sensitive to the impact of alcohol. Okay, so managing blood pressure, some items to check out. In my book, I focus a lot on chapter 3. This blog post is very popular. I give people 6 steps, very unique steps, not the usual steps, where I've actually helped them lower blood pressure through natural lifestyle changes. So that's a blog post you can check out on my blog. Now let's talk about insulin resistance. This is our carbohydrate traffic problem. How can we fix this? But before we can fix it, how do we measure it? How do we know we have a traffic problem in the first place? Well, you check your fasting blood sugar. If your fasting blood sugar in the morning after a 10 to 12 hour fast is consistently 100 or above, that's a sign of prediabetes, so that can be an early sign of insulin resistance. If it's above 125, 126 and above, that defines diabetes. Now, if you have borderline sugars or family history, you should ask your doctor to get a test called the A1C. The A1C is a composite score. The problem with just one blood glucose number is just one data point in time. You might be a little bit elevated in the morning, but you might be okay throughout the day, so then that's not as much of a concern. But the A1C, it tells you your average sugar for the last 3 months. Last 2 to 3 months. So that's a number that we should get if we have any issues with insulin resistance in the family or if your sugars have been high. And then, coming back to this, high triglycerides and low HDL, this is the key. That is an early sign of insulin resistance. Now, a lot of doctors define insulin resistance, that carbohydrate problem, they wait for the sugar to go up. And I tell them, don't wait for the sugar to go up. If you have high triglycerides, you have pre-diabetes. By the time your sugar starts going up, already your body's losing the capacity to use sugar for energy. If you can catch it at the high triglyceride stage in yourself or in your kids, you'll find out that we're seeing tons of kids now with high triglycerides. That's when you immediately want to fix it, because that will preserve that pancreatic function, so it won't lead to type 2 diabetes later on. How do you improve it? Kind of similar to the triglyceride slide. Again, we want to reduce the added sugars and excess carbs, increasing muscle. Okay, when you add more strong muscles to your body, they can burn sugar more effectively. So that's one key thing, because many of us, when we exercise, might be focused more on cardio, and cardio is absolutely important for your heart. But if you've got that carbohydrate traffic problem, you want to make sure you amplify that muscle, because it will burn sugars more effectively, which means it's going to take more carbs from your diet towards muscle and away from fat and away from liver. Increasing your baseline activity steps, we'll talk about that during exercise, adding some cardio a few times a week, and then again, the stress and sleep factors can actually elevate sugar. So one example I'll give you is I have some patients in my clinic now that wear continuous glucose monitors. 24/7, their glucose is being reported out to an app on their phone. And many of them have fixed everything from their diet and exercise standpoint, but they still have elevated morning sugars. And I've told them even before they got the monitor that it's probably your bedtime and your stress levels, and they don't believe it. But the minute they start tracking their data 24/7, they are shocked that when they go to bed 1 hour earlier, when they shut their device off and do something mindful or read a fiction book, that over time their sugar gets better. And why is that? So let me explain to you why that happens. Why does nighttime stress and digital stimulation raise morning blood sugar? Let's go back to evolutionary times, okay? So if we were out in the savannah and we had to go to bed at night. Nighttime is a vulnerable time. You might get attacked by predators during that time. Your body is on high alert. So what happens is your body produces stress hormone, and it activates your liver to produce a slow pulse of sugar during the nighttime. Because if you get attacked, you need that sugar to run the heck out of that, your hut and get away from danger. Our body is still designed that way, except it doesn't know the difference between that tiger outside and your phone messages, right? Or your texts that you're getting at nighttime, your work texts. So when you're going to bed in an activated, and this feels normal to us because it's part of life, when you go to bed activated and hyperacute and you're looking at screens, it sends that same signal to your liver to produce more sugar throughout the nighttime. And until we can fix that, I know that one takes a lot of work, until we can fix that problem, often we will never see that morning sugar improve. So just keep that in mind. So now let's talk about body fat, our favorite topic, okay? So this is the way I explain body fat to people. There's two types of body fat, and I don't know if I should use a jelly donut. This may not be sending the right message. I'm not telling you to eat the jelly donut. This is a model of what body fat looks like. So there's two compartments of body fat. The outer fat is the subcutaneous body fat. That's the visible body fat that usually contributes to more of our mass weight. The inner fat is the visceral or inflammatory fat. That's the jelly inside. The red jelly inside, that visceral fat, is what contributes to increased heart attack, heart disease, stroke, cancer risk. Now look at the ethnic distribution. This is one of the reasons why certain ethnic groups like Asians and Indians can be at higher risk at lower body weights. In a typical Caucasian body, the ratio of jelly to donut is about even. It's about 1-to-1 maybe. In African Americans, they tend to have less of the inflammatory fat and more of that outer crust. So they can become very overweight without developing glucose issues, but their heart disease comes because African Americans have a disproportionately higher rate of high blood pressure. So they get kidney disease and heart disease from high blood pressure. But look at the Asian diagram here. A tremendous amount of jelly, which you can't necessarily see. It's in the triglycerides in your blood, it's in your liver, and just a thin rim of basically that subcutaneous fat. So that's why they can be underweight but just carry the wrong types. Now, I always think evolutionarily, why is that? Why were Asians evolved to be like that visceral fat? The reason is because we're talking about inflammation being a bad thing in the modern world because it's continuous. Again, if we go back to the savannah during evolutionary times, when you carry extra belly fat, those inflammatory chemicals, that's kind of like an immune system support. Because when you're out in the, wherever, the savannah, the woods, the forest, whatever, you might be encountering all types of infections and parasites out there. So having a little bit of extra belly fat can protect you against that. But that's a pulsatile thing. That's during times of feast, famine, whatever. But if you chronically have that elevated visceral fat, then that can lead to more heart disease risk. So let's look at what this looks like. Okay, so these are two famous obesity researchers, and I just want to make the point. This is a British doctor, this is an Indian researcher, and they partnered on a lot of interesting studies. But what I wanted to show you here is their body mass indexes are identical. This is the height weight composite score. They both have a body mass index of 22.3, but then what they did was they got a DEXA scan. DEXA scans are usually done for osteoporosis screening, but they're also used to measure body fat. The dark purple is basically body fat. So this guy who looks bigger, they're both actually at an Indian wedding. You can see the saris back here. They're both at a wedding. And you can see that this guy, despite having the same BMI, he has much less purple areas than the skinny Indian guy right here. Because this skinny Indian guy is basically storing a lot of fat in these other areas that are not as visible. He's got much more visceral fat. And you can see when you measure their body fat, same body mass index, 9.1%. This guy's in single digits. And this guy on the right, he's at 21%. And when you interview them, this guy's a runner, he eats really healthy, and this guy, he admits that I eat a typical Indian diet, and the only exercise I get is stepping off the elevator. I never take the stairs. Even though he does all this research, is basically pushing the buttons on the elevator is the only exercise he gets. But again, culturally, a lot of people that see people like this, you think that, wow, this guy needs to eat more, right? This is the guy that the mother-in-law, the spouse is like, this guy needs to gain weight, right? Another point of conflict in the clinic is, wives don't like it or husbands don't like it when the other spouse is too skinny because it makes the other person look more overweight, right? So then when I get them to lose more weight, it causes a lot of tension, but I have to explain to them that even though he's skinny, we actually have to add more weight, but we have to add more muscle mass because he's lacking the muscle that can burn the carbohydrates that can reverse insulin resistance. So you're trying to improve body composition and not just dropping weight. And this is just another slide that shows that inflammatory fat, that belly fat, does release hundreds of different chemicals that can increase inflammation, blood clotting, and all types of other factors. That's why it's really key that we keep that visceral fat down. One very popular resource on our Palo Medical Foundation page that I built several years ago is an Asian Adjusted Body Mass Index calculator and also waist-to-hip ratio calculator. So this is a good resource for you to know because there's different body mass index cutoffs for different ethnic groups. So that's a good resource for you to check out. Now, I want to make a quick point about smoking, okay? Hopefully most of us in this room are not smoking. It is the strongest reversible risk factor for heart disease. It can increase LDL and triglycerides and lower the healthy cholesterol, increases blood clotting. You guys might know this already. Smoking we think of as lung cancer, profound impact on heart attack risk. But here's the part that I think might raise some eyebrows. Even 1 cigarette a day daily is deadly. I go give a lot of corporate talks and I still see people out in the parking lot in the smoking areas. And they tell me, I'm a social smoker, just a scotch and a cigarette on the weekends. But this study done in 2018, just let's spend some time on this because I'm sure all of you might know somebody or might be somebody that smokes 1 to 2 cigarettes a week. It showed that males who smoke 1 cigarette daily, they have a 46% greater heart disease risk and a 25% greater risk than non-smokers. Females, 57% higher heart disease risk and 31% greater risk. And you might think that smoking 1 cigarette daily has 1/20th the risk of somebody smoking 20 cigarettes, but it's actually half the risk, right? So that 1 cigarette has a huge problem. Now, if you're smoking 1 cigarette on top of having increased belly fat, high triglycerides, huge problem, okay? So you're just compounding all those risks together. So I tell people social smoking is deadly smoking. Quit it 100%. There's no amount that's healthy at all with cigarettes. Now, advanced tests. So you might have gotten the standard blood tests by your doctor. There are some additional tests that can be useful. There's a blood test called the HSC reactive protein. It can test your body for inflammation. So many of my patients that have high cholesterol, they might have other risk factors for heart disease. We're not sure if they need cholesterol medication. I might check a C-reactive protein to see if they have high inflammation levels. I mentioned that you can do an advanced lipid profile in some cases to break down the size patterns. There's a test called the Lp(a). I want to talk about that in a second. And the heart scan I'm going to talk about too. These are advanced parameters. What is Lp(a)? So this is a really important cholesterol particle. It's like an LDL cholesterol particle, but it's even more dangerous. What it does do is it sticks to the blood vessel wall, and it causes tremendous inflammation, damage, and blood clotting. And if any of you have a family member that's had early heart disease, like a sibling or a parent, if you've had a parent or a sibling that had heart disease, males less than age 55, females less than 65, there's a good chance you have an elevated Lp(a). You should ask your doctor to get it checked. It's very overlooked and not often checked enough. But when that is elevated, it significantly compounds heart disease risk. And it's actually the association, it's 10 to 20% of the population. It's even higher in certain groups like Asian Indians. Asian Indians have the highest incidence of elevated Lp(a). So being Asian Indian alone is probably a risk factor, but if you have a family history, you should absolutely get that checked. Now, quick point about heart scans. This is a test I sometimes check. If you are at high risk for heart disease, it's something you may want to know about or talk to your doctor about. In the old days, the only way we could look at your arteries is by doing an angiogram, but there is a test called an EBCT. It's a heart scanner, and you can look for calcium inside the arteries of the blood vessels, and that calcium is an actual surrogate marker for plaque formation. I've caught some early heart disease in patients that actually had a positive plaque score. And thank God we checked it because otherwise we would have just been waiting for the heart attack to happen. So a positive calcium score is an indicator of heart attack risk. We don't check it in everyone. There is some radiation involved. We usually tend to check it in people that have intermediate to high risk. We're not sure if they need to go on a statin medication, but this is a test that can be done so you can discuss it with your doctor. So now let's get to how do we reduce these risks. So let's come back to my traffic diagram. Remember what I said, our goal for everyone in the room is we want to get more glucose and carbohydrate traffic going to the muscle parking lot. So how do we do that? A few different ways. The first thing is we have to lower the amount of carbohydrate traffic going to the muscle. So let me make a really key point for you here. This is really important for nutrition. Your muscle parking lot has a fundamental disadvantage. It has limited parking space, especially if you're not a bodybuilder. All of our muscle parking lots have fixed limited parking space. Our fat parking lot, unlimited space, open 24/7. That's why we can gain hundreds of pounds of extra body fat, right? Our liver, it can take on a lot of traffic and convert it into fatty liver, and it can convert it to blood triglycerides. Now here's the issue. Let's say today you ate pretty healthy, you didn't eat too many extra carbohydrates, you went to bed at night, okay, so you probably filled your parking lot. Most of us are filling or overfilling our parking lot on a daily basis. Then you wake up the next morning. Do you think your parking lot is empty the next morning? There's no reset button overnight. It's still full. So if you wake up in the morning with a full muscle parking lot and you have one innocent slice of whole wheat toast, maybe a bowl of oatmeal, there's no place for that oatmeal to go. It's not going to go inside there. It's going to go towards fat storage, triglyceride production, or it's going to stay in your bloodstream. So when people ask me, is oatmeal good or bad? It all depends on context. If you've been physically active and the oatmeal is going to be part of a carbohydrate restrained eating plan, it's not a problem. But if you ate like crazy, you went to the buffet, Saturday, and then you wake up and you're having oatmeal, that oatmeal is going to be the straw that breaks the camel's back. It's going to lead to high triglycerides, body fat storage, fatty liver, and all of that. So your goal is not only to lower the amount of carbohydrate traffic, you need to clear parking space on a regular basis. And what that translates into is your muscles have to be active on a regular basis. Anytime you engage muscles into exercise, it's burning energy and it's clearing parking space, so then more carbohydrates can go in. And the types of activities that do it, walking, all these things, but if you want to rapidly clear a lot of space, do something that tires out your legs. Go for a hike. Do intervals, go on the elliptical machine and turn up the resistance. Anything that produces leg fatigue is rapidly actually clearing parking space. Interval training does it too. And interval doesn't mean if you're not somebody that can run, even my mom, I tell her when she goes for a walk fast, slow, fast, slow. Walk for 10 minutes to get your heart rate up, but then alternate. If you have hills, go up and down hills. Anything that produces alternating intensity or leg fatigue will clear more parking space. And then you can enjoy some, not unlimited amounts, but some carbohydrates after that. So that's what you're trying to do. And then adequate stress and sleep. When sleep and stress are not controlled, often the body will not let go of fat. It's not going to let go. It's going to hold on to it. And often it can drive less carbs to muscle and bring more towards fat too. So that's another thing that's often overlooked. Okay, so now that we know this, let's do a couple of things here. So now that we understand insulin resistance and inflammation, which meal do you think might contribute to higher insulin levels and inflammation? The one on the left is vegetarian, right? You've got a nice Indian flat plate there. You've got all those beautiful round, carbohydrate bombs, and you've got the rice, and you've got all this wonderful thing. We always include this decorative tomato and one cucumber. It's just decorative. We don't actually eat that. It just adds color to the plate. But then the rest of the meal looks like that. Or, a vegetarian Asian noodle dish. Compare that to maybe something that's got more protein, less starches, and more colorful vegetables, right? So I think we know which one's going to trigger more insulin issues and more inflammation. And so this is a sample plate, and applying this to one culture, but you can apply this to any culture really. But usually what I tell people is one critical number for you to follow. Again, let's get back to the foundation here. We want to lower insulin resistance. We don't want to form type B particles. The easiest way to do that is to change the way you eat. So what I tell people is if you're going to track a number, use like MyFitnessPal or Fat Secret or some sort of nutrition app, and just pay attention to how many grams of carb am I eating each day. More specifically, I have my patients check how many grams of net carb, which is your grams of carb minus the fiber. And typically on a daily basis, if you're eating, the average sedentary worker here in Silicon Valley, if you're eating more than 100 to 150 grams per day, your triglycerides, your numbers are going to go up most likely. Okay, so now let's look at this snapshot from my book. Is this person that's having one piece of flatbread, 1 cup of cooked lentils, and a potato-based curry. In that one meal, it sounds so innocent, there's 94 grams. That's how much I eat on an entire day. That's one meal right there, right? So that's how it adds up. So my typical Asian, this is Indian Asians or even my non-Asian patients, often they're eating 300, 400 plus grams of net carb per day and they're not clearing parking space. So all this excess carbohydrate is causing fatty liver, triglyceride, and the type B particles. So this slide tells you how to calculate net carbohydrates. This is a mnemonic that I use for a lot of my Indian patients, but you can apply it to anybody. I call it CARBS. The C stands for chapati, and in Indian that's flatbread, so you can call that tortillas or bread. The A is aloo, which means potato, which are starchy vegetables. The R is rice, okay, so rice and grains. The B is beans, and the S is sugar. Now, people, I made this very clear in the book that we're not going to eliminate these foods. These are staple parts of our diet, but you need to mix and match your portfolio properly. You can't spend it all on eating carbs in one meal, right? So maybe I'll have a little bit of this curry with a little bit of lentil, then I'll have some vegetables. But I'm not going to have rice flatbreads and all this together, because then in one meal, like you saw with Smita, your numbers are way above the charts. So that's what we're really trying to optimize. You've heard this before, but really, we need to add more color to your plate. Often, my patients, I have them take pictures of the things that they eat. And it looks like a black and white photo. Everything is just gray and brown. You know, it's just white, brown. You don't see bright colors at all. So I tell people each of these different colors has a different purpose for your body. It can lower cancer risk. It can protect your brain. So really that saying eat the rainbow is really important. Like I said, if you have sugar issues, eating more vegetables than fruit, you know, snacking on vegetable snacks, mini cucumbers, all these things can have incredible benefits in terms of lower cancer, heart disease risk. And this has really been a fundamental strategy. And I'm so happy. When I wrote the book, I was teaching people how to make cauli rice. Cauli rice is one of the most important things you can do, and now they sell it. You don't have to use a food processor or a shredder. You can find cauli rice at Costco, at Trader Joe's. And the reason it makes such a huge difference, you will burn more abdominal fat eating cauli rice and doing sit-ups. And the reason for that is because cauli rice, it's just cauliflower that's pulverized and shredded into rice grains. If you do the math, a typical serving of rice or flatbreads can be 30 to 50 grams of carbohydrates. But if you filled your plate with cauli rice, it's less than 3 grams. And it's anti-cancer nutrients. It's cruciferous vegetables. So often I teach my patients, how do you make your vegetables look like carbs? Okay, so you can do that with noodles, spaghetti squash, zucchini pasta. Even if you love rice, I tell people don't just eat rice plain. Eat it like an Asian fried rice or an Indian biryani, where you use 60 to 70% less rice, but mix vegetables, nuts, seeds, paneer, shrimp, chicken, whatever you want. Add vegetables, protein, and fat instead of just eating plain white rice. It changes the chemistry of what the glucose does to your body. It also lowers the total amount of carbohydrates. So these are some real key things to do. In terms of healthy fat intake, monounsaturated fats are heart healthy. So these are oils that come from olives, avocado oil, nuts, especially almonds, you know, Brazil nuts, cashews. If you want to know more about nuts, I did a dedicated blog post on nuts. It teaches you everything you need to know about nuts, and then seeds as well too, and then of course the plain avocado itself. These are excellent sources of heart healthy fats. Omega-3s are also heart healthy. If your diet allows it, we want to get it from cold water fish, but nuts and green leafy vegetables. I put fish oil capsules up there. For some people it might be useful, but more updated studies show that fish oil capsules are not as heart protective as we used to think. So if we're trying to lower triglycerides, the best way is still through diet and not by taking the omega-3 capsules. There might be some risks with omega-3s in certain people as well. Now the big question, what about saturated fat? We get this all the time. Is coconut oil good for you? Is butter good for you? Is ghee good for you? Is full-fat dairy good for you? And the answer isn't black or white. It looks like it depends. Different people respond differently to saturated fat in their diet. If you use it like the usual culinary amounts, like you're using a little bit of coconut oil to cook, a little bit of ghee to cook, most people, we don't see elevated inflammation, we don't see elevated cholesterol levels, but there are some specific genes that I put up here. Some people that have these genetic markers, they have very significant elevations in their cholesterol from eating even a little bit of ghee or butter or coconut oil. So the main thing I tell people, I don't check these genetic tests. I tell people anytime we make a dietary change, let's check your baseline cholesterol, and then let's recheck it 2 months later. If they're eating a lot more eggs, a little bit more butter, etc., then we recheck it. If the numbers didn't change much and they're looking better, which they most often do if they're eating all the other right foods, I don't worry about it. They can enjoy it in moderation, but some people are really sensitive. Even small amounts can cause more of an issue. But what I would tell you is regardless of that, you do need to diversify your fat intake. Some people, because of all the press behind coconut oil and ghee, are eating primarily saturated fat. But I tell them that as much as in many people, ghee and coconut oil may not raise heart disease risk, it has not been proven to be heart protective. The oils that are heart protective are the monounsaturated oils. So when you're cooking and eating fats, you should basically diversify. So add some of the monounsaturated fats, use the olive oil, use some omega-3s naturally from foods. You can add a little bit of the saturated fat, high quality in addition to that, but be sure to get rid of the really bad fats that are served in snack foods and restaurant foods. That's one of the issues. When you guys go to a restaurant, if you're eating out a lot, many people are like, yeah, when I order DoorDash because I'm too busy to cook, I always get the low carb stuff, just like you told me. But what they don't realize, even when they go to the Indian buffet, they're like, I'm not going to eat the rice. I'll have the salad and I'll have the meat, whatever. But what they don't realize is the oils that they use in the restaurants are more damaging than the carbs. The oils that they use are usually omega-6s, which are inflammatory, and they don't tend to typically clean up the pots every time they cook. They recycle the same oil over and over. Getting back to inflammation, those cause direct inflammation in the body. I'm not banning restaurants. You should go out, enjoy yourself, have your Sunday dinner. But for people that think they're eating low carb on a daily basis because all their dinners are coming from restaurants or lunches, you're trading one problem for another. Yes, your carbs might be low, but your inflammatory oils and fats are extremely high. And there's rarely any place in the Bay Area that I know, even when I go to corporate cafeterias, they've got wonderful food there. They're usually using the wrong oils. So that's why I just choose to bring my food if I can, because I'd rather not eat the inflammatory oxidative byproducts. So a healthy plate is typically, I tell people for most patients, half the plate you really want it filled with vegetables, multicolored. A corner of it is going to be your protein, the healthy fats in the middle, and then starches in this corner. And I dial this up and down based on my activity levels. If I went for a big hike or I did a workout that induced some leg fatigue, I can be more liberal with my starch intake. I can up dial that to maybe 20, 25% or so. I can go higher on that. If I did a lot of weightlifting and I need to build stronger muscle, the protein can actually go up. Maybe I can eat slightly increased portions of chicken and meat. If I'm sedentary, I look at my Fitbit, my Apple Watch, I hardly got any steps, I didn't walk all day, I've got to really keep the carbs under control. It's proportional to my daily activity levels. If you can think like that, then you can still enjoy the starches in the right way, but you're not going to over-enjoy them on days where you're not producing any muscle demand for energy. So most common question I get is, how do I get more protein in the diet? So to address that, I did very detailed posts, one specifically for vegetarians, but it's also applicable to non-vegetarians, but it teaches you how to get more protein into your diet in a healthy way, and that can really have a lot of health promoting benefit. Alcohol, here's the big question. This is where I get nervous because my father-in-law is in the front row, okay? Right? We've talked about this a lot. So August 2018, Lancet is one of the most prestigious medical journals. And it's a study, and basically what it did was it looked at alcohol use and disease burden, not just heart disease, but every acute and chronic condition, cancer, Alzheimer's, everything, accidental death. And they looked at it from 1990 to 2016. Most of the studies out there on alcohol and heart disease are poorly designed. They're not statistically powered properly. So this one was a very detailed analysis. And doing this analysis, I wanted to ask you guys, let's take some guesses out there. How many drinks per day were associated with absolutely no increased risk of disease? What was the right amount to drink to improve health? Oh my God, you guys are impressive, A+. 0. That was such a sad, sad thing. But what they said was, even though a small protective effect for heart disease was found, it was counteracted by the risk of cancer, injuries, and communicable disease. But you don't have to put your alcohol away. Let me provide a little bit more context here, okay? So here's the situation with alcohol, and this can be applicable to a lot of different types of studies. Context matters. What they found in these studies is typically people that are drinking in moderation, let's say 1 to 2 glasses of wine every day without going overboard. What types of people are those usually? Usually they come from a higher socioeconomic profile. Usually they have better incomes, they're educated, they're literate, they have better access to health insurance. So it's not necessarily that the alcohol is really protecting them, it's just that they come from a socioeconomic background where they've got everything else working in their favor, right? So that's really what we're finding. We call it the healthy user effect. That's different than somebody that's not drinking moderately, that's abusing alcohol. So really alcohol, the issue is what context. Are you having it on a regular basis in a healthy environment, in a social way, and not overindulging? That may not have any increased risk. It might have some protective benefit. The protection is probably the fact that you're a social person that enjoys life. That's more important than what's actually inside the wine glass itself, versus somebody who's self-medicating. And I ask this in the clinic. I'm like, I can tell some of my patients, they're suffering. They're unhappy with their job, with their spouse, with their life, and they have to have 2, 3 scotches. And it's not like the scotch is increasing their heart disease risk. It's the life around it. It's what's motivating the scotch and the beer and the wine. So if you think of it that way and you provide that context, then you can understand. So that's why I tell people, never start drinking for health benefit. It doesn't do it. There's a million other things you can do, but don't start drinking to protect your health. It's really more this kind of subtle association that explains a lot of differences in alcohol intake. Sitting time, okay? Feel free to stand up anytime, but we are finding that increased sitting time increases death. You might have heard this in the news, but the one thing I want to mention to you, which is really important, is most of the studies show that even people that exercise 30 to 45 minutes a day, if they're spending time doing prolonged sitting, it still increases their heart disease and diabetes risk. And I see this often in the clinic. People go to the gym in the morning, they work out, and then they sit for 8 or 9 hours because they think they already did their activity, right? I see some people knocking on here, right? So that's the problem, is you have to interrupt prolonged sitting. When you sit for more than 30 to 40 minutes at a time, your body produces hormones that store more abdominal fat, that raise your blood sugar. So I actually tell patients, I'm happy you're going to the gym, but I want to find out what you're doing for sitting and standing. That's the foundation of physical activity. Do you use a stand-up workstation? How many steps are you getting? If those are sound, then of course you want to layer on some activity on top of that, but don't use one as a substitute for the other. That's the most important thing. So now we have all types of devices, but now it's funny because when these things first came out, people really used them and paid attention, but most people don't use them anymore. They just use them as a timepiece. Nobody knows how many steps they're taking anymore, but we really need to use them in the right way. And what I tell people is try to aim for hourly steps and try to get at least 4,000 steps by 1 p.m. The reason I say that is because some people do all their walking in the morning or they backload it in the evening. But if you get enough steps by 1 p.m., it's ensuring at least that your walking steps are distributed evenly throughout the day. The newer generation Fitbits, watches, they've got the stand-up reminder. Those are really important features. Even if you stand up for a few minutes or get a few steps in, you just want to interrupt that prolonged sitting. Increased inflammation happens from prolonged sitting as well. Okay? So remember, we need better parking spaces, muscle parking lots, okay? The stronger our muscle parking lots, we can indulge in a little bit of extra carbs. And the ways we can do that, I tell people, as much as maybe you came from a country where you didn't do these crazy boot camp exercises, our bodies are designed to do these types of activities, So lifts, taking any sort of weight and lifting it, using your whole body so the legs are strong, you're using your core. Squatting is a very Asian Indian, it's a very typical position that a lot of us have lost out on because we're sitting in chairs, but it does restore hip mobility, it engages the legs, and then suitcase carries and farmer walks are basically carrying weights around. These things really engage the whole body, and I really recommend my patients that are above age 40, 50, they do these, because I tell people, what's the point of doing all these complex movements that they do in boot camp, where you're jumping off a plank and doing all this crazy stuff? I want to make sure that when I'm older, that I don't have to ask somebody to carry my bags. I want to be able to load my own bags in the overhead compartment. So that's why this is important. I want to be able to carry things with no issues at all, with proper balance, right? I want to be able to do this sort of motion because that translates into everyday life, into quality of life. That's what we're really looking for. So for exercise questions, I did a very detailed 2-part blog post. The reference is up there, but I teach people how to exercise in the safest way possible. I see a lot of people in Silicon Valley, they've got a corporate boot camp, they sign up for a class, they feel really good, but then they get injured. They blow out their Achilles, they hurt their knees, and all of a sudden they can't do anything. So there's a very systematic way that I teach people to start exercising. I go over that. And then the other tragedy is I've seen I should say a growing number of people that have had a heart event while exercising. So some of the patients that I see, they might have been exercising at their gym, their corporate fitness center, and they had a heart attack or a stroke while they were exercising. And the problem was that they didn't realize that they had plaque inside their blood vessel, and then they did an activity that raised their heart rate and stress levels so high that it caused a plaque to rupture. So really, if you're somebody who's high risk, you should actually see your doctor and you should get medically cleared. Oftentimes these patients have to get a stress test before they participate in these sorts of intense activities, CrossFit, whatever you're doing. Otherwise, walking, light to moderate exercise is fine, but if you're going to do something really intense and you might have risk factors, make sure you get those checked out. Really important. Now, what about stress? I mentioned stress. So I want to explain to you how stress scientifically causes heart disease. So this is something from a dedicated stress talk that I do. So basically, I want to show you what happened to our ancestors versus what's happening to us now. So I tell people basically when it comes to your blood vessels, okay, when our primitive hunter-gatherer ancestors were under stress, their blood vessels would tighten. And that was a good thing. You know why? Because if they got cut, they stepped on a sharp object and they started bleeding, you want the blood vessels to tighten so you don't bleed to death. But in somebody who's just sitting at work stressing out all day and their blood vessels stay stiff, they get high blood pressure from that, right? So something that was adaptive has become maladaptive. What about high blood sugar? We talked about this a little bit earlier, but high blood sugar provides energy to the body so you can flee or fight danger. But unfortunately, chronically high blood sugar in somebody who's just inactive all day, that leads to conditions like insulin resistance, prediabetes, and diabetes. Belly fat. How can belly fat be adaptive? Well, if you live in a feast-famine society, I tell people during times of famine, your belly fat's like your Tupperware. It stores calories, and you can use that fat for energy so you don't starve to death during times of famine. But I tell people, we now live, what happens in the winter? We don't famine, we feast even more. We never empty our Tupperware. We keep filling that Tupperware. Our body has to find places to shove it, the liver, the body fat, whatever, but that's where it has become completely maladaptive. And then inflammation. Actually, interesting, we talked about this already. It triggers immune system to defend the body. So that's good if you're out in an environment where you're exposed to all types of infections. But like we talked about, on a chronic basis, it can lead to plaque formation and other chronic health issues. So this is related to this. I wanted to show this to you. I know it's a very busy looking slide, but I did just want to indicate in the last column, there is on the last row the HS or the C-reactive protein. This guy had very high C-reactive protein, above 10, and he dropped it down to 3.6 through diet and lifestyle changes. And then he dropped it from 3.6 to a perfect level of 0.6. And the only change he made was he started meditating. So this is numerical evidence. And I've seen this in my patients who are sleeping better and they start meditating, their inflammatory markers often go down. So that just shows you, because I know for a lot of us, meditation, mindfulness is a black box, but there is biochemical evidence that it can actually impact your immune system in a way that can lower inflammation. So keep that in mind. This is my own data. Now we can really look at what my numbers look like. Why am I so passionate about this? Because you can see back in 2009, now that you know how to read these numbers, my HDL cholesterol was 28. Now look at my total cholesterol in the left column, 154. So a lot of doctors might look at that and go, Dr. Sinha, your cholesterol looks good. It's less than 200. 154 is great. Don't worry. My triglycerides were 314, okay? And then my LDL came back at 85. All right, so look at my ratio. My ratio is 11.2. What should my ratio be? Do you guys remember? Less than 3, right? Less than 3.0. So I was 11.2. But a lot of people that don't know this, they would say that, you know what, the most important number is your total and your LDL cholesterol too. So again, my LDL looks really good. But I know based on my triglycerides, remember I said when your triglycerides are above 150 or 200, you are almost assuredly making those dangerous type B particles. I knew that already because I checked my LDL size and it come back B is bad. Right? And the problem is when you have B particles, they make your LDL look good. They trick you and they trick your doctor. Your doctor will look and say, you look good. Your triglycerides are 200, your LDL is 100, don't worry. You should worry. In fact, it's so predictable that in many of my patients, when they fix their diet and they improve their numbers, I said, expect that your LDL might go up. And that's exactly what happened to me. So and I'll show you how I changed my diet. After I changed my diet over time, you can see that my triglycerides dropped from 314 to 74. HDL naturally went up. I told you they're inversely proportional. My ratio dropped to 1.6, but look at my total cholesterol. It went up 30 points. An untrained eye would say, well, you're eating too much ghee or butter. What happened? But that's because my HDL, my healthy cholesterol, went up. My size pattern went from a B to an A, right? Everybody in the room likes it when their B's go to an A, right? We all like straight A's. So B to an A. So I had the larger particle. My LDL went up, but in a healthy way, because when your LDL gets larger in size, often the LDL will go up as a number. So this is really important stuff. You're not going to get this from most doctors, but the ratios, everything went in the right direction. And for me, again, I'm using an app. I was checking my carbohydrates, because at that time, when I had 314, I exercised a lot. I was eating steel-cut oats, bananas. I was eating whole wheat stuff. I was eating salads, everything. But when I calculated my net carbs, look at my breakfast, Trader Joe's steel-cut oats and a banana. It came out to be 47 grams of net carbs. I know from tracking my numbers, when I get above 100 or 150, it goes up. The triglycerides go up. So in one meal, I was getting almost 50 grams. Now, if I were to eat something like a Mediterranean omelet, veggies, cheese, whatever, it's got more fat, more calories, but the carb substitution is 3. Right? So a significant reduction there. So that gives you an idea of how calories really in many cases don't matter. It's the composition of the foods itself that are really critical. Okay? So real quickly, this case study I wanted to bring up because I know we're all concerned about not our own health, but our kids and everything, but this is somebody I saw several months ago. So this is a 32-year-old entrepreneur who came to see me with his parents after having a massive heart attack during a high-intensity exercise class. 32-year-old entrepreneur. He's extremely successful, very fit. He's a former collegiate athlete. He eats a pretty unhealthy diet, high stress. His parents are very concerned because he's a workaholic who gets very little sleep and doesn't know how to relax. So how and when did his heart disease begin? So we had a very in-depth conversation, and I won't forget this conversation because it's been repeated many times before, but we talked about the fact that the parents were getting very frustrated with him because he couldn't control his life. And, you know, they said that he doesn't listen to us. We tell him you need to rest more, you don't need to make so much money, just relax and chill out. But then, you know, I asked him a question. I asked him, what were you guys like when you were his parents when he was younger, right? What was happening then? And it's an important point to ask because a lot of us, when we're parents, we're caught in the rat race. We see what's happening around us. My kid's got to do this, we got to do that. You know, they need to do this activity. They got to go to Stanford, they have to be an entrepreneur. You get caught in that rat race. But then as a grandparent, you have different perspective. How many grandparents are out there? Raise your hand. Now keep your hands up if you feel like maybe your kids are pushing their kids a little bit too hard. Well, we saw some, it's okay, yeah. That's what happens, right? You lose that perspective. And the issue is a lot of times you're going to reflect back and think that maybe it wasn't worth it to have them do so much and just go, because now the parents can slow him down. He's on a train where he can't slow down at all, and it took a massive heart attack. And even still, I'm working with this patient. It's very tough to slow him down. So that's why I want to be fair that what is the greatest risk factor for heart disease? And the greatest risk factor is actually age. And for a lot of people, what's happening in modern civilization now is the risk factors, the high triglycerides and those risks are starting in 9, 10-year-old kids and teenagers. So by the time they're 30, 35, their blood vessels have been exposed to chronic stress, high triglycerides and sugar for 15, 20 years. That's why we're seeing heart disease happening earlier. Think about our kids now, right? They don't play anymore. All the parks, they have cobwebs everywhere because nobody's playing on the playground structures. Nobody rides their bikes unless they're riding their bike to math class or to school, right? And because of that, every generation of kids is going to face heart disease, obesity, chronic disease much earlier, and we're seeing that pattern happen already. Remember, I told you the process starts in childhood. Okay? The triglyceride to HDL ratio, this pediatric journal showed that when your triglyceride to HDL ratio is high in kids, my wife's a pediatrician, she used to see this all the time in kids. That already predicts increased stiff arteries later in life. So this is starting very early on. Okay, so I tell people we have to redefine our kids' report cards. We're focusing on the left side, but many of our kids, when it comes to exercise, diet, socialization, outdoor play, they're not passing the marks. And a lot of that is on us. It's our responsibility. They don't know any better. We have to instill those habits and get them started early so they don't end up like the 32-year-old executive who on paper looks great. He's the one you're going to put on a pedestal and say, you work hard and you can be like him. But I see him in the clinic. I know what his marriage is like. I know what his finance, I know everything because I often see the spouses too. So don't get carried away with this and make sure, and I'm not saying that you should demotivate your kids, but if you're doing so many activities that your kids are going to bed at midnight, they're eating junk because they have to go from Kumon to this, to piano to that, and there's no time to make food, so just eat this vegetarian burrito, eat this sugar, eat this smoothie, whatever, and that's where this disease starts happening. And then when they get into high school and college, they don't know any better. We never taught them how to eat healthy, so they're not going to learn it in their 20s and 30s, and often this is going to happen before we actually make that realization. Okay, so now question of the day, what factor is a greater health risk than obesity, is as dangerous as smoking 15 cigarettes a day, and raises heart attack and stroke risk by 30%? And no cheating if you came to my prior talks. Can anybody guess what that risk factor is? That's a really good guess. That's the one I would guess. Yes? Stress, really close. So it's actually loneliness. Okay? This is turning out, it's been shown over and over. I didn't believe it at first, but now that I looked at the data, loneliness is turning out to be one of the most profound risk factors for heart disease, for cancer. And I was trying to understand what the science is. There's actually a couple of genes that are linked to loneliness. So when we perceive our lives as being lonely, we see this a lot in our community here. As we age, we start to see this. Kids are out of the house. For immigrants that are coming from large extended families and now they're living a nuclear family life, we have this perception of feeling alone. And again, coming back to evolution, whenever we feel alone, we feel like we're in danger. There's a specific gene especially that becomes activated with loneliness, and it causes your immune system to start overreacting. So this is really important. Again, as we think of our kids, are they socializing enough? Or are they completely absorbed in activities that are disconnecting them from their friends? As we age, are we still keeping our connections and staying social? There's now hard science. And look how profound. It's as bad as these other risk factors. And that's why there are some communities you can look at, some ethnic populations, where their lifestyle risks are not very good, their diet's not good, but because they have sense of community, their heart disease risks are actually very low. It's incredible. So that has a really big factor. This is another post I'd refer you to. This is one of the most popular posts I've written in a long time. It was written in the end of June. It's called "This Single Thought Process Can Ruin Your Health." And it gets to the underlying sort of psychology of why we end up with a lot of health issues. A lot of people reached out to me and said this really made a big difference in their life, sort of understanding this process. So just some posts for you there. This is my blog where you can pick up more information. My book, I've got a few to look at in the back, but you can find my book on Amazon. We've been designing a lot of wellness programs now, too, for people who want to learn more about their health. I work with a company, too, that actually does personalized profiling that can actually customize your diet based on your metabolic risk. And they actually work out of here, and they can do profiling in India as well, too. And I even worked with the same company that does low-carb, anti-inflammatory flatbreads. So we know we can't live without our flatbreads. So this is a company, they've got their breads out in Indian grocery stores, and you can actually subscribe to them as well. But they're very tasty and much healthier than the usual stuff that you can find. For a lot of people that complain about fatigue, if you go to my blog, I have a free ebook there that has information on fatigue. People throughout Silicon Valley have been using this as a reference. And with that, I loaded you with a lot of information, so we'll open it up to questions. Yes? Oh, should we have people come up just to, okay, maybe that'll be better. Right, so yeah, you can come up to the mic here so we can keep track. Yes, exactly. Yeah, feel free to stand up at any time. Yeah.
Meals, many small meals, one big meal. I've heard both are better.
Sure. Yeah. No, great question. So there's a lot of words about intermittent fasting. Should I eat 3 meals with mid-afternoon, mid-meal? So when it comes to coming back to insulin again, the problem is a lot of what we're taught about, in terms of trying to keep your metabolism up by eating more frequently throughout the day, that works for a minority of people. But every time you're putting most foods in your mouth, you're causing a glucose and insulin spike. I'm actually more of a fan of keeping more space between the meals. So one popular way of eating is intermittent fasting, or we call it time-restricted eating, where you do all of your eating within a fixed window, and then you allow your liver and body to fast for 12 to 14 hours. So for example, you might eat everything between 11 a.m. to 7 p.m. That's 8 hours. And then for 16 hours, that gives your liver time to cleanse. That works much better. When I'm trying to reverse insulin resistance and diabetes, we need to create space in between eating episodes. Because remember my parking diagram right there, right? One of our goals is we need to keep clearing parking space, and we have to keep the liver cleansed as well too. And one of the ways to do that is to give our body not only physical activity, but also increased space. And the way you can incorporate this into your life, you don't have to do it every day, but typically I do it around social occasions. Like if I went to town Saturday night, we have festivity seasons coming up, and let's say you went crazy on Saturday night, you know that you've loaded your liver and your muscles. So then Sunday is a great time to intermittent fast, or Monday if you did it all weekend. Monday, Tuesday, Wednesday, I often will skip breakfast. If you're hungry, do the lowest carb option possible. Stay physically active, and then maybe eat your first meal around 11 or 12. So it's a good way to detoxify the body from eating episodes. But to answer your question, I think it's better to actually space out and not eat so frequently, because that causes more glucose and insulin spikes. Okay? Make sense? Did that answer? Yep. Come on over. Yeah, I was going to ask you, did that make sense? Did that answer your question, or? Sir?
Yes, except my doctor told me to do exactly the opposite. He said, don't ever eat a large meal.
Okay.
This is Newton's third law of diet studies. For every diet study there exists an equal but opposite.
I know, right. So what, a big picture I want to say about diets is even if you're eating that frequently, if you're eating the right types of foods, it's probably, and okay, so let's come back to the problem with insulin. If you don't have any signs of insulin resistance, and your body weight, everything's fine, and you're eating that pattern and you're okay, I'm not going to force you to do intermittent fasting. For some people, having 3 meals and a couple snacks might work fine. But in today's modern day civilization, I find that pattern of eating is leading to more issues because we're just not burning as much energy on a regular basis, and our foods have become much more calorically dense. So I'm not saying it's an absolute, but I would say for many people, having space makes a lot more sense. So great, thank you. Yes?
Hello, doctor. Maybe related question. How do you know that your muscle parking lot is empty? It can start taking more.
Oh, I have an app. It tells. No, I'm kidding. No. Yeah. Someday there will be probably. But okay, so how do you know when it's empty and it's ready to take on? So there is no direct way to know. But the way you can subjectively tell is, my rough rule is if you do any sort of exercise or activity that induces pretty, palpable leg fatigue. So if I go to the gym or I do a workout, usually it's hard for me to walk after that workout. I mean, it's pretty, it takes some effort. So that sort of activity has cleared parking space. Now, how much parking space? So I wish I could tell you that usually what I tell people is for every 45 minutes to an hour of average activity that induces some leg fatigue, you could probably have on average an extra 50 to 60 grams of carb. The very, very general rule of thumb. I have some patients that are elite athletes, and their level of intensity and activity, they can eat double or triple the amount of carbs that I can. So it varies, but that's a general rule of thumb. But to answer your question, there's no easy way. It's more a sensation of the leg fatigue and things.
So does hunger indicate you're ready to take some more? Or?
No, it doesn't, because hunger is driven by so many other factors. Hunger often here is driven by stress. That sends a signal to our brain. It has nothing to do with our legs. Many of us are sitting all day. We're not even using our legs, but we're eating constantly, right? So there's definitely not a sign of leg fatigue. It's more just we're bored or we're stressed or there's other cues to that. So yeah, the human body mechanism, it's not very specific at sending that signal out. So yeah.
Thank you.
Thank you for that question, yeah.
Hello, Doctor. A lot of great information. Thank you.
Thank you.
A couple of things. You mentioned you showed a plate half of vegetables
Yeah.
into that. Coming from an Indian origin, should the vegetables be cooked or non-cooked? Which is better? Is one better than the other? That's one part of one
Sure,
question.
okay. Cooked or raw vegetables, okay, that's the
Right.
first part.
The second question is, the more we read about these studies that come out, they
Yeah.
seem to contradict the previous study.
Oh, of course.
Right? So you mentioned about the coconut oil. For a while, we thought that was the worst oil. Then
Yeah.
we thought, oh, that is the best. That's a health food, right?
Yeah.
Now the latest study a few weeks ago said that's the worst thing.
Yeah.
That makes it confusing. So if you can throw some light on that.
Yep, okay, sure.
Thank you.
So a couple of things. The first thing on the vegetables is I think a mixture of having some raw and cooked vegetables is the good average way to go. Some people who have significant digestive issues can't break down and process food. If they have a lot of bloating, a lot of acidity and things, raw vegetables don't agree with them. So lightly cooking vegetables is fine. It can help your body digest it. I just tell people not to overcook it, like our pressure cooked sabjis and Indian curries where there's no consistency at all. You've lost pretty much all the nutrients. So you want to cook at a level that retains texture and some of the color of the food. That's the key thing. But I have plenty of patients that without even touching salad, they've done fine, with that. So it's not that raw foods are absolutely necessary, raw vegetables, but if you do cook it, lightly is key. You're asking a much bigger question about the coconut oil and studies. And literally 1 to 2 months ago, I did exactly a post on how to interpret studies properly for the exact reason you brought up. Because nutrition studies are notoriously the worst studies on earth. The way they're designed, because most of them are based on food frequency questionnaires. They take a population of people and they say, what did you eat for the last week? Fill this out. And then there's all these confounding factors that makes it very inaccurate. So what I would tell you is for things like coconut oil, for red meat, for all these numbers, first of all, know your own numbers in health. What's your body weight? What are your metabolic numbers? What's the impact of that food on your body? And then the last thing is moderation. If you read a headline that red meat's okay, that doesn't mean you're going to be eating steak every day. You still have to keep your meat portions lower, but you don't have to be worried about just eliminating it completely. You still have to surround it with the right food. Same with coconut oil. The pendulum swings back and forth on that. I've seen plenty of people in the context of a healthy diet do phenomenal. Inflammation numbers, body weight, everything's down. I'm never going to take coconut oil out of their diet, but I tell them, mix it with extra virgin olive oil. So the pendulum, like I said, you're going to see different headlines every week, but at least we can tell you that these foods, if you try them on your body, you feel good and your numbers look good, you don't have to worry, okay? There's some foods, high fructose corn syrup, excess sugar, we just know unanimously that they're bad for our body, but those foods, I think you just have to test on your own. Go ahead, I can hear you, yeah.
What worries me is that these studies, because we don't know if the effect is long-term or not. So if the study says coconut is good, if they start being coconut in water,
So one thing 10 years
later, if it contradicts, then
sure. But I'll tell you that coconut oil has been around a lot longer than Lipitor, okay? Because I'm being honest in telling you that a lot of my patients are put on drugs that were accelerated through the pharmaceutical pipeline, and they've been only on the market for like 3 to 5 years, and we only find out 10 or 15 years later that this diabetes drug causes pancreatic cancer, right? So we're always taking that risk, but at least in foods that we've seen, I've seen my grandmother, we've seen generations of people thrive and do well. And I think the problem is sometimes we hyper-focus on these foods, but that's why I kind of focused on big picture things, just activity, stress, loneliness, community. A lot of those things will counteract that. So I wouldn't over-obsess and worry, and that's the problem with these studies. They just take one component and they kind of exaggerate that. So I think you'll be fine. But I understand your anxiety. I'd be anxious too seeing all those headlines. Yes?
Hi, so I work in a clinic that serves predominantly the underprivileged and uninsured community. And not long ago, we had a patient come in who's a taxi driver, and so he has a very sedentary lifestyle. He doesn't have the luxury of time to prepare a meal. he has really long exhaustive hours, so he doesn't have the luxury to be able to be exercising or like preparing healthy meals for himself.
Yeah.
So what would be your recommendation for a patient
It's
like
tough.
that?
I have a handful of patients that are cab drivers and they work in those industries. It's really hard because they work such long hours. But the one thing, I have a couple of patients that did really well, and the one thing that was really empowering for them was to understand that if they change the nature of the foods that they eat, they can make a lot of difference. So to give you an example, in most of my patients, I find that we can get them 70-80% of their goal just through food changes. They don't have to exercise a whole lot. Exercise is really important, but just sitting down with this particular cab driver and finding out which places he was stopping to eat, and he didn't really realize the impact. He has fatty liver. And I told him that basically the sugar-sweetened beverages you're having are causing that. We know that alcohol causes liver disease, but so do frappuccinos, right? So do frappuccinos and sugar. So he didn't realize that link. So providing that education was key. So as we modified the diet, and even though I can't get him to, based on economics, he's eating a lot of fast food, I did say that, all places they do lettuce wrap burgers. Like, can we get rid of the fries and this? And you can have some of the meat. Did you know if you added some tomatoes or had a salad with that particular food, it's going to do better? And it's remarkable how much better they feel. And the nice thing is once you get that and you can get people to lose like 8 or 10 pounds, they feel a little bit more motivation and energy. And all of a sudden they might be getting more walking steps in. So that's just not even a lot of my patients who just are averse to exercising, they feel really down. I try to change the foods in subtle ways to improve their mood and energy. And then the next step will be, can we even do a 5-minute walk? Can we do that? So I think that might be a good approach for him.
Okay, thank you.
Thanks for that question. Thanks for the work you do.
I have a question about the leg fatigue that you were talking about as being a good indicator
Yeah.
of how well you've worked out. Any particular reason why leg exercises are better than whole body or, why legs?
Yeah, no, good point. So I'll tell you, and I'm not saying, so let me clarify, I'm not saying you should do leg fatiguing exercises every day, because obviously if today you did a really intensive leg workout and your legs are fatigued, your legs are going to need rest for the next couple of days. So then you're going to be doing other types of activities, body weight. But the reason I'm emphasizing legs so much is a few reasons. Number one, they're the largest carbohydrate storage containers in the body. So when the legs get strong, you burn a lot of sugar. And given the fact that we're sitting so much, most of us are losing a lot of leg muscle. Okay, so that's one of the reasons you counteract it. The second thing is if you look at the root cause of type 2 diabetes, it starts at the muscle. And if you look at scientific animal studies, it starts with the leg muscles. And one of my theories is when you look at the Asian body, it tends to be typically a little bit of a pot belly and very slender limbs. I think as the legs get stronger, and I see that in my practice, that gets better. I'm going to give you a couple of other reasons. I want to motivate people to do squats and lunges. They did a study that looked at identical twins, and they were following brain health over several years. And they looked at every factor: stress, diet, nutrition, plant intake. And they found that the factor that was most correlated to preserved brain health was leg strength, which was unbelievable. Okay, so, and then finally, in terms of overall aging in general, if you want to be the most independent, the one factor that shows all the time is leg strength. Leg strength is an indicator, and just think of how our relatives age, right? I think about my parents and grandparents. First they start off walking confidently, then they walk slower, then they walk wider, then they're using a cane, then they're in a wheelchair, and then they're bedbound. It's all because after age 50, 55, accelerated leg muscle strength goes down. We're facing that already in 30, 40-year-olds who are sitting at the desk all day. But if there's one change you can make in your family, your parents, I've taught my mom all the leg. She can't do everything I can, but I've taught her to do modified squats. Things that can really preserve leg strength is a game changer in every possible way. So thanks for that question.
Thank
you. Thank you.
Thank you, Doctor. First of all, such an informative session.
Thank you.
A quick question. You talked about the importance of sleep. So if you need a sleep of, let's say, 7 hours, and if you sleep for 6 hours in the night, and if we take rest, let's say, for half an hour or so in the daytime, is it kind of equally good, or?
Yeah, can you just add them all up together?
Yeah.
Take a nap in the car and add it onto the, exactly. I see. Okay, so here's the situation here. Okay, sleep is complex. So first of all, the most important thing about sleep is not the quantity necessarily, it's the quality. If we get enough deep phase, there's different phases to sleep. Deep phase sleep is the one that helps us live longer, feel better, more refreshed. It regenerates our brain. It does everything. Now, here's the issue with deep phase sleep. It happens in the first half of the night. So if somebody tells me, I got 8 hours of sleep, I went to bed at midnight and I woke up at 8 a.m., versus somebody that went to bed at 10 p.m., right, and got up at 6 a.m., Those are two completely different animals, those sleeps, even though they're 8 hours. And the reason is because one of the key hormones that's released during sleep is growth hormone. Growth hormone is the most important hormone during sleep. It helps us preserve muscle, it reduces Alzheimer's risk, everything. And the peak spike in growth hormone happens between 10 p.m. to 2 a.m. So I'm already getting my pajamas on at 9 p.m. I'm like I'm out most nights at 10, between 10 and 10:30, so I can catch that natural spike. Because after 1, 2 a.m., you'll get little surges, but you'll hardly get what you did the first half of the night. So I tell people my late nights are my early mornings. If I have to get work done or do anything, I'd rather get to bed early, get that growth hormone in, and get up at 5, 4:30 sometimes, and get other work done. So that's a key thing. Your question about naps, unfortunately, usually when we nap, it doesn't make up for the loss of deep phase sleep. Most of us are getting light phase sleep during the nap, and naps are refreshing. I love naps. Sometimes they just energize me like crazy, so I think they're important, but it's not a one-to-one. Definitely like a 20-minute nap at 3 p.m. is not the same as you sleeping 20 minutes between 10:30 to 11 p.m. Totally different animal altogether. It's bad news. I wish your theory was right. I like your theory better, so. I'd rather stay up late.
Thank you. Just a quick follow-up here. So if we were living in a different time zone, if I'm sleeping rather than 10 o'clock, if I'm sleeping at 11 o'clock, as long as it is consistent, does it still matter that,
Oh, interesting. Yeah. So it all has to do with wherever you live. It happens to do with the timing from sundown. Okay, so basically after the sun, it's based on pretty much the home location you're at. So you have to equate it to your time zone of where you're at versus, an alternate time zone. So,
that answers.
Great.
Thank you very much.
Okay, thank you. All right.
What is the recommended frequency of getting your annual lab? Is it annual or is it more often?
That's a great question.
And another part of that question is I have a hard time getting my primary care doctor to order like annual labs because, they say, oh, you're fine. You come back like every other year.
Yeah.
They won't even order HbA1c for me. And I'm looking at the C-reactive protein and it's going to be really hard to get my primary care doctor to order that.
The traditional healthcare system, these aren't, and I got to say in most patients, I don't necessarily get the C-reactive protein. I get it when I'm faced with a decision in somebody with insulin resistance, high triglycerides, those factors, then I get it. Otherwise, I agree, it's not a good test to check in everyone because sometimes you get false elevations. They can be for different reasons. But to answer your question, the standard guidelines might say once a year physicals, but really even if you're in your 30s and 40s and your numbers look great, like you have no signs of insulin resistance, getting checked every year is probably fine for those people. Now, if you're seeing upward trend lines, like over the years you're normal, but the A1Cs or the glucose is going up, then I'd be more adamant about getting it every 6 months, every 4 months, or something like that. So I tend to use more frequent intervals in people that look like they're showing upward trends. It motivates them and we can stay on top of that. But there are a lot of doctors, they're following the standard guidelines and they don't want to go outside of that. Insurance may not cover it. You do have the power, by the way. There are a growing number of labs, including labs online, where you can actually self-order your own panels. And I have some patients that are actually getting their labs checked through that. So we're pretty much at an era where people are going to be able to order labs like they can order DoorDash. So, yeah. Right. So, thank you. Yeah.
Hi, doctor. You mentioned cancer. So I had a question about cancer and glucose. I have read that all our body cells are able to metabolize energy either from glucose or from fat, except the cancer tumor cells. They somehow don't have the ability to metabolize fat and they get their energy only from glucose. And they suck up all the glucose. So that raised me a logical question. I'm an engineer. So if, say, somebody has cancer, whichever terminal stage it is, then if they simply cut out all the carbs from their diet and eat only fat and protein, wouldn't that mathematically guarantee that all the cancer cells would die out?
So it's a great, this is why I love working in Silicon Valley, because I get questions like that, right? So, what happened to, is fat good for you or no? No, but you're actually addressing a really key question. I actually did a blog post on that. So you're basically saying the type of diet that pretty much brings carbs down to that level is known as the ketogenic diet. And the ketogenic diet is being scientifically studied as a cancer therapeutic. So the whole point is, can we starve the cancer cell of its primary fuel source, which is glucose, and just feed the body other things? And it has been shown in some forms of cancer to have benefit. It looks like it has to be paired up with standard cancer therapeutics. I know some patients that have tried it, and it hasn't necessarily led to complete remission in most cases, but it might be a powerful adjunct to make chemotherapeutics more powerful. Intermittent fasting and some eating plans that can lower sugar have been shown to reduce recurrence of specific cancers, and breast cancer is one of them. There's a pretty well done study that showed that breast cancer recurrence does go down with intermittent fasting. So you're right with the concept. And if you looked up ketogenic diet and cancer, there's lots of ongoing trials around that right now. So yeah, you're thinking along the right lines. Yeah, thanks.
Thanks for the wonderful presentation, Dr. Sinha.
Thanks.
I have a question. I've been brought up thinking that like a glass of whole milk is a great thing to take every day, and I insist my kids do that too.
Yeah.
But I also hear that like the whole milk, there are two schools of thought. Like milk is not really a human food.
Sure.
For grown adults. What's your thinking behind it?
So just as a reference too, so I'm only saying these references because I know a lot of you like to dig into the science, but if you go to my blog and put in dairy and dairy risk, I cite a lot of studies on dairy. And dairy is one of those things that's kind of variable too, but in most population studies, dairy fat actually lowers the risk of diabetes. And a recent one came out within the last 3 months to show that association. So there's specific nutrients in dairy fat, anti-inflammatory fats that can keep lower sugar. In kids, they've shown 3 studies, one of them a Harvard-based study, that kids that drink whole milk retain a better body weight than kids that drink skim milk. Just because of the abundant nutrients in it, it's more satiating. So I'd say for most kids and adults, the data looks pretty good in terms of the healthy effects of dairy fat, and it does help people moderate intakes of other foods like sugar. Having said that, some people are dairy allergic, and I don't mean just the easy ones that you can test. Some people have inflammation in the body, and typically dairy allergies can be eczema, excess acne, inflammatory type stuff, so then it's worth doing a dairy-free, but for most people, I find dairy to be fine in the diet.
Thank you.
Thanks, yeah.
Hi. To reduce carbohydrates, would replacing whole wheat pasta with the pastas that they make from vegetables be a good choice, or is that more processed food?
That's a good point. Like, you mean like the edamame pasta they have and things like
exactly.
that?
Or
no,
spinach.
it looks like a lot of those vegetable-based pastas. I mean, it looks like the carb load in that is less. You're right, it is more processed, but if the ingredients just show that it's mostly just a vegetable and they haven't added a bunch of other things to process it, it's probably fine. And it does tend to be lower glycemic. So, yeah.
Okay, thank you.
Thank you, yeah.
Hey, this is for my parents. They are already diabetic. So they're taking medicines. So is there a way to stop medication by changing their diets?
There is. I mean, that's what I do in my clinic. My goal is to reverse diabetes. But what I would say is you have to be pretty motivated, you have to be supervised, you have to be ready to make some food substitutions. Some of our generations, a lot of our relatives in India, there's just changes that are very difficult to make. So I think the goal in a lot of our relatives is, can we minimize medications? To eliminate would take a lot of motivation and ability. If they have that motivation, then it's possible. But I would say the goal would be to minimize and to slow down the progression of disease so they don't require insulin and things. But some of the strategies that we talked about in terms of reducing the total amount of carbohydrates, raising that awareness. A lot of our Indian relatives in India, for example, they'll have toast in the morning for breakfast. They don't have any protein. When I do protein intakes, most of us are very deficient in the amount of proteins we're taking in. So if you add protein to their diet, that alone can actually mitigate some of the glucose surges from that. So there's ways you can manipulate the diet. And then if you see the sugar levels are getting better, the A1C is dropping, you should talk to the doctor about whether you can cut back. Because some doctors especially, they're so busy, they don't change the medication list unless you sort of proactively ask them, what can I do to do that? So, okay.
Thank you.
Thanks. So I guess we'll take these 2 more, because I know we're at the end of, is that right? Is that okay? Okay, okay, great. Yeah.
First of all, thank you for a very informative talk.
Thank you.
My question is about, you mentioned about doing all these right things and then the lipid profiles improve.
Yeah.
But the question is more about like what does it do to the arteries? Like, does it, like, if you have like all these accumulated stuff.
If you already have plaque?
Yeah.
Good question. Yeah.
Does it really reverse any of that, or like how does it, like, what is the impact?
Absolutely. Oh, so basically you're talking about if you have plaque already, all these things, will it have an impact, or are you sort of doomed with the plaque, right? So really what it comes down to, I tell people, you think of that plaque as being an earthquake fault or a volcano, okay? And what happens is a lot of these dietary and lifestyle changes we talk about is we don't want the fault to become active, or we don't want the volcano to erupt. And the way to do that is to manage the stress, the lifestyle, and all of these things. Now, if you were to check, for example, a heart scan in 5 years again, it might show the exact same score that you had before. You might have the same amount of plaque, but you've chemically changed the plaque. You've stabilized it so it doesn't erupt. So it has a dramatic impact. And that's why people that have lifestyle changes after their first heart disease event, yes, the actual plaque itself may not disappear, but it's a completely different conformation where it's not going to erupt as readily, and that can add decades to your life. So that's the goal. Now, with the newer generation scanners, we might be able to see more microscopic changes in the plaque to know that, okay, this dietary change led to the plaque becoming more stable. But with the ones that are more widely available, it's hard to get that nuance. But for example, some of my patients with plaque, if their belly fat went down, their C-reactive protein got better, we know we're stabilizing their plaque. Their risk is going down, even though we don't see it visibly shrinking, at an aggressive rate. Great.
Thank you.
Okay.
Thank
I'm
you.
nervous about his question. Okay, but I'll have you ask first.
Yeah, thank you for your presentation.
Sure, yeah.
A couple of quick questions. One is, does it matter the carbs, the source? Like if I'm getting 20 grams from a banana versus 10 grams from raw sugar.
Yeah.
Is it like...
Good question. This is really key. So this is the problem. So you guys remember when they had the low-fat movement? We talked about that. What types of foods did they create, right? Entenmann's pastries, right? All these low-fat things that had a lot of sugar in it. And then sugar, now we're facing a whole sugar crisis. So the big point is now with the low-carb movement, they've created a whole industry of foods and packaged bars that are low-carb. And what they're using is they're using artificial sweeteners, other types of foods. And the issues with these types of foods, if you're eating the wrong type of carb, is yes, it might be the same amount of carbs, but it can feed different parts of your body. So I'll give you an example. If you have 30 grams of sugar, when you have 30 grams of sugar, let's call it an Indian sweet, Diwali is around the corner, okay? We have that. All of that's absorbed in the bloodstream pretty much. Everything's in the blood directly. It goes straight shot. What if we had an apple, okay? Apple's got some glucose, it's got some fructose. When we eat the apple, because the apple has fiber and nutrients around it, when it gets into our intestine, only about half of it gets absorbed into the system. The other half actually goes directly into our colon. It's encapsulated by the fiber, and it feeds our healthy gut bacteria. It actually feeds a bacteria that can actually help with our long-term blood sugar control. So it's very different. So I'm glad you brought that point up, because now everybody's so, and I maybe contributed because I have people such focused on carbs, but you have to know what the quality of that carbohydrate is. For rice, for example, as much as you can manipulate things. So rice, for example, if you were to cook rice and then you cooled it and you reheated it, the more times you cool and reheat rice, the less the rice will be absorbed into your bloodstream, believe it or not. It's interesting things like that. That's why the way Japanese eat rice, like cold sushi rice, that will cause your glucose to go up less than just having hot rice out of a cooker. So there are ways you can manipulate the carbs despite what the gram to gram ratios are. So
thank you. Good. And the second question is cardio enough for you?
Is cardio exercise enough?
Yeah.
I think cardio exercise is great, but remember the disclaimers I put. If you're doing cardio as an excuse to sit all day, no. If you're doing the type of cardio that's not necessarily counteracting the prolonged sitting and not doing enough leg strengthening, it may not be enough. Cardio is great, but again, based on your profile and your risk factors, you might have to do more aggressive weight training. I think for most people, given our modern work, cardio for most people isn't enough alone because we sit so much. So you have to add a little bit of leg training on top of that to make up for the prolonged sitting that we do. So, yeah.
Thank you.
Good. Okay. Thank you guys for staying the whole time. That was a long talk on a Sunday. I appreciate it. Thank you.
So much for coming. Thank you again to Dr. Vaughn for such an excellent talk this afternoon. If you can please complete your surveys and return them to us at the back table, that would be fantastic. You can also sign up for Cupertino Library Foundation's email list, and we will be sure to send you the link to the recording of today's talk as soon as it becomes available. And we have some copies of your book as well back there that you can take a look at as well. We also have them at the library. Thank you all so much. I hope you enjoy the rest of your day.